Hello, thank you for joining me for lesson 2. Today's lesson is based out of chapter 4, Cardiac Anatomy. We will go over morphological markers in fetal heart development, an insight into normal cardiac structures for each chamber within the heart. I would like to share this quote before we get started. In a world of shades and shadows, it takes the clarity of black and white to truly see the bigger picture. Today's lesson is based strictly in black and white pictures just to highlight the morphological markers found within the fetal heart. Let's begin. Let's start with the four chamber heart. So I placed here 5 facts of the four chamber heart. The first fact is that the four chamber heart should be 1/3 of the fetal chest. It should point towards the left side. This direction is known as level cardia. It should be at 45 degrees, depending on the gestational age, plus or minus 15 to 20 degrees. So if you have a heart axis that is greater than 65 degrees, that is abnormal. Or if you have a heart axis that is less than 25 degrees, then that's considered abnormal as well. You also want the four chamber heart to be positioned on the left side, majority of the heart to be positioned on that left side. That is known as level position. And then another highlight to point out, take a look here at the descending aorta. Notice it is also on the left side. So it should be to the left of the spine. These are all the normal morphological markers for the four chamber heart. All right. Now we're looking at the crux of the heart. So the crux of the heart is known as the center of the heart. So that's the joining of the interventricular septum with the interatrial septum, as well as the atrioventricular valves, which you can see here, the mitral and the tricuspid. Now, some things to point out when you're looking at this particular area, you want it to be completely intact. So this is where you check for your VSDs or your ASDs. You also do not want the two atrioventricular valves to meet at a linear insertion. So the tricuspid valve should be slightly upward when you compare it to the mitral valve. So it should be some upwardness with the tricuspid valve. Also, to point out, the mitral valve is the inflow for the left side, and the tricuspid valve is the inflow for the right side. So, just to keep that in mind. I placed here so you can see that again. So, the atrioventricular valves are the valves that separate the atria from the ventricles. So, with the mitral valve, just to remember that it is associated with the left side, L, left. And then for tricuspid, you have the R here. For the right side, these are known as the inflow valves. Now, as for the outflow valves, is your aortic and pulmonary. So then you have the aortic left, which shows no bifurcation, and then the pulmonary right shows bifurcation. And this is significant to tell these two apart. So the pulmonary right side has a bifurcation, whereas the left aortic valve does not. Okay. All right. So now the first chamber we're going to discuss is the right ventricle. Now, the right ventricle, which is on this side here, this is the most anterior chamber. So it's the most anterior chamber of the heart. It is known to be crescent shaped and heavily trabeculated. Okay. The moderator band, which is highlighted here on the image, is somewhere near the apex. Now, just to reiterate on the tricuspid valves, they have 3 leaflets, which is composed of anterior, posterior, and a septal leaflet. Again, to reiterate, the TV inserts more apical than the mitral. There is 3 papillary muscles associated with this right side. as well as the chordae tendineae from the TV valve. It inserts into the right ventricular wall. So all of these features here are morphological markers for the right ventricle. Very, very important. Okay. Next one is the left ventricle. Now just look at the image. We just went through the right side and we learned that there is a moderator band that's in the near apex of that side. And we also learned that it is the most anterior chamber, which we can see in this image. And we also learned that it's heavily trabeculated. Now, let's compare it with the left ventricle. Notice on that left ventricle, it's smoother, nice and smooth. There are no bands. It's not trabeculated. It's just nice, smooth walls here. And also notice that this left ventricle is given more of the apex. So it's more of the apex here, the left ventricle side is. It's also bullet shaped. You can see in this example. Now remember that right side was more crescent shaped, but that left ventricle is more shaped like a bullet. Now the leaflets of the mitral valve are described as just having two. So you have an anterior leaflet and a posterior leaflet. This is known as the bicuspid atrioventricular valve, so there's two. There is, once again, no moderator band. And also, there's two papillary muscles, but it's free of the ventricular wall. So keep that in mind. So everything's two with the left ventricle. Right is more associated with three. Okay. Now they did want to point out, and we're going to see this again when we get to the left ventricular outflow tract, that the anterior leaflet of the mitral valve, that is the leaflet that is continuous with that ascending aorta view. So we're going to see that when we get to that section. Okay. All right, let's go now into our atrius. So our atrium is we're starting with the left atrium. The left atrium is the most posterior chamber. Okay, so what did we learn already? Right ventricle being the most anterior chamber. The left atrium is the most posterior chamber. Okay, also to note that left atrium is the closest to the descending aorta. We also learned earlier that that descending aorta is on that left, to the left of the spine. So it's on the left side as well. Now, another marker for the left atrium will be the pulmonary veins, which is 4. Now, I listed here how you can, because usually depending on which view you're in, you're not going to see all 4. Most of the time, you just see 2 at a time. So in your 4-chamber view, you are actually imaging the right and the left inferior pulmonary veins. And it's when you're in your 5-chamber view, you're seeing the right and left superior pulmonary veins. Okay. Most of the time, from your apical view, you're actually imaging the right and left inferior. Another important landmark for this side is that the foramen flap, which you can kind of see here, that foramen flap is on the left side. This is a characteristic for the left atrium. And to keep in mind that when we get to color flow, the flow in the foramen, normal flow, is from right to left. So right to left is the normal flow for the foramen. And then another thing to point out is the left atrial appendage. Now, this was a test question I had. It wanted to know just the makeup of this left atrial appendage, and it is more finger-like and narrow. Okay, so just you should highlight this because this was a test question of mine. It just wanted to know the difference between the left atrial appendage versus the right atrial appendage. The left atrial appendage is more finger-like and narrow compared to the right side. Okay, so these are all morphological markers for the left atrium. All right, here's another one. I decided to put this on a separate slide because it had a little more detail to add, and that is the coronary sinus. Now, this is a part of the left atrium, but with the coronary sinus, you see it's like a slit like what you can kind of see here right below the atrial ventricle valve on that side. And it's sort of like a straw. So the straw is coming from the left side, heading over towards the right atrium. Okay. Now, some of the important structures for the coronary sinus is just where it's located. It is located with that left atrium, slightly post, you see here, to the mitral valve annulus. Another thing to point out is that it enters the right atrium. It's right, so right where we saw that from Raymond flap, it's right below there and just above the valve of the IVC. Okay, now it serves as the main coronary venous return. And one important thing is that the Thespian valve is located at the opening into the right atrium. Very, very important, because I had a question asking me the difference between a Thespian valve and a Eustachian valve. Okay, so the Thespian valve is associated with the coronary sinus, and that's like the doorway into the right atrium from the coronary sinus, the Thespian valve. We're going to learn about the Eustachian valve when we get to IVC. Okay. All right, so here we are at the right atrium. Now, the right atrium is responsible for receiving, we just learned, the coronary sinus and the SVC and the IVC. Okay. Now, here it talks about the right atrial appendage. It's hard to see here the right atrial, or just I have another picture where I can show you the difference between the right atrial appendage and the left atrial appendage. But for now, we just want to be familiar with its shape. So the right atrial appendage is more pyramidal shape, whereas the left atrial appendage was more finger-like, narrow. The right atrial is more shaped like a pyramid. Now the Curie network are net-like strands seen associated with the tricuspid valve annulus. Okay, so just remember net-like or network for the Chiari network. Another important thing, I had two test questions on where the SA node was located and where the AV node was located. So I do want you to highlight these two. So the SA node is located within the right atrium, so that's one, but it's on the upper side, just under the SVC. And the AV node is on the floor of the right atrium near the CS opening. Very important to remember. Now, the lining of the right atrium is made up of pectinate muscles. Okay. And then what separates the walls here is this ridge, the crista terminalis ridge. All these are tongue twister words here, but crista terminalis ridge separates the smooth wall from the coarse wall. These are all features known in the right atrium. And one last thing we were discussing earlier about the Eustachian valve is that this valve is more near the opening of the septum. So it says here, IVS inserts near the IAS, so interatrial septum, with the valve opening is the Eustachian valve. Okay, so that's the difference between this valve here and the Thespian valve. So let's go back. Thespian valve is more, it's the doorway out from the coronary sinus, located at the opening into the right atrium. And the Eustachian valve is located near the interatrial septum, near the IVS insertion. Okay, but all of these are markers for the right atrium. Okay. All right, so now let's get to the outflows, the semilunar valves. Now, in order to achieve this view comes off the right ventricle, okay, and it's heading towards where? The left shoulder. So you kind of like sweep on down. As you follow this RVOT, angle towards the fetus left shoulder, then you'll eventually reach the bifurcation. And I have an image here on the right side. So you see the bifurcation of the left pulmonary artery and the right pulmonary artery. Okay. Now, separation of this is what tells you that this is the RVOT versus the LVOT. This goes back to what we learned about the semilunar valves, where the pulmonary valve is associated with that right side that has a bifurcation. The LVOT does not have a bifurcation. So, this bifurcation is the characteristic for the right ventricular outflow tract. Okay, let's go next one. Here is the left ventricular outflow tract. Now, this is different. So, the RVOT is heading towards the fetus left shoulder. The LVOT is heading towards the fetus right shoulder. Okay. Now, what's associated with this LVOT is the aortic valve. This valve is within the ascending aorta. So, as you focus on the left ventricle, which you see here, left ventricle, the LVOT comes off the left ventricle towards the right shoulder. You follow it, and you're going to eventually reach the aortic arch. Okay, it should just go that smoothly. Now, what we were talking about earlier about the mitral valve, that anterior leaflet, it should be a continuing way. Just follow that right along into that ascending aorta. A lot of times, and I've seen it where there's a VSD, because it's a separation of that mitral valve to the ascending aorta. So it's a very common view for some VSDs to happen. You just want to make sure that it's all complete and as one. You can see that here in the top portions here. Just a nice continuous of that valve to the ascending aorta. Okay. All right, so back to the RVOT. Now, this outflow tract, which is important to remember, is composed of the pulmonary valve, which then leads to the pulmonary artery, which leads to the ductus arteriosus, and then eventually the descending aorta. One other thing to remember with this guy is that when it crosses, so when it does the crisscross with the LVOT, the pulmonary artery crosses over the aorta prior to the bifurcation. So before we get to the bifurcation, we are going to cross over that ascending aorta. Okay. The semilunar valve that prevents blood from flowing back into the right ventricle is doing diastole. So that's what shuts off the valve with the blood pumping. It prevents blood from flowing back. Okay, just to point that out. But what's really, really important is to remember is that it crosses over the aorta anteriorly, and that is composed of these here: pulmonary valve, pulmonary artery, ductus arteriosus, and then the descending aorta. Okay, let's go to left side. Okay, so this LVOT, which is known for 5-chamber view, and what is it composed of? It's composed of the aortic valve, which is here, leading into the ascending aorta. All right, we'll just keep following it around. So it's heading there. It's going to kind of loop around to the aortic arch. And then after that, it leads into the descending aorta. Okay. Right angle. So it's going towards the right shoulder. Okay. Inferior to the pulmonary artery. And once again, semilunar valve prevents blood from flowing back into the left ventricle during diastole. So it kind of shuts off. Okay. All right. So let's move on. All right. So I placed here because just imagine you have your left ventricle, and then you have your aortic valve, and then here's part of your ascending aorta leading to the aortic arch. Okay, so we have the arch and then the descending aorta. Now, one thing to remember here with the ascending aorta is that it's like a cane or like a candy cane. Another thing or characteristic to point out with the aortic arch is the 3 branches that arise from it. The ductal arch do not have branches. We'll get to ductal arch here in a second. But for the aortic arch, it has these 3 branches that arise from it. And what are those 3 branches? You have the brachiocephalic, first one. That's also known as the innominate artery. Then leads to the left common carotid, and then your left subclavian artery. And how I remember these guys is that it's in ABC order. Okay, so brachiocephalic, left common carotid, and then left subclavian artery. Those are the branches that make up the aortic arch, and it's known for its candy cane shape. Okay, so these are normal morphological markers of the aortic arch. Next, we have the ductal arch. Now, the ductal arch, notice right away, it's more flat top, whereas the aorta had more of that arch or candy cane shape. The ductal arch is more flat top. Another thing to point out is that, once again, there's no branches. No branches are a part of the ductal arch. And so in this case, it's known as a hockey stick shape. And that's how you know the difference between the ductal arch versus the aortic arch. Now, one thing to point out is that it involves, here we see it coming off the right ventricle, coursing around to the pulmonary valve. Here's main pulmonary artery, leading on to the ductus arteriosus, and then the descending aorta. Okay, so that's what I wanted to show. So just to point out that it does not have any branches, and then the parts that it's composed of. Hockey stick. Okay, all normal characteristics. All right, now here, when we start to look at the short axis plane of the heart, there's 3 parts that compose of the short axis views. Now we're going to start with this high short axis view, which is composed of the great arteries. Now in this particular example with the high short axis view, you want to point out that you see, yes, the pulmonary valve, which is here, and then the aortic valve. I have a diagram here so you can see the cusps that's involved with both valves. Very important to remember, because this was a test question. They wanted to know what were the 3 cusps for the aortic valve versus the 3 cusps for the pulmonary valves. So to keep in mind, for your aortic valve, it's the right coronary cusp, which you see here, left coronary cusp, and then the non-coronary cusp. Okay. Now for your pulmonary valve, they are referred to as anterior, left, and right. Very important to remember this for your exam. Okay, the difference in the 2. All right, so this is also known as the high short axis view of the great arteries. Now let's move on to the short axis, still short axis views, but we're kind of just sweeping down. Okay, so we started off with the high short axis view. Then we're going to get to the papillary muscles, as well as the mitral valve. Okay, now just starting with the ventricular septum. In this view, we can see, so if there's usually like a VSD of some kind going through the septum, you can usually reproduce that VSD within this view as well. Okay, so keep that in mind. And then also another good thing about this view is that you can M-mode the AV valves. So when you get to the plane where you see the tricuspid valve and the mitral valve, look at this beautiful waveform that you can achieve. Now, of course, since right is at the top, you're going to have the tricuspid valve here with your septum in the middle, and then your mitral valve just below. Okay, so it's more than one view usually for that short axis plane. Just keep that in mind. Starting with the high short axis view to evaluate the valves and their cusps, and then the septum, the papillary muscles, and then the valves, which includes the mitral and the tricuspid valves. Very, very important. Okay, and that's it. Now, there's a few more things that we are going to need to discuss. I just didn't want to overwhelm you with everything all at once. So, for the next lesson, we will finish up the rest of cardiac anatomy. It's just a few more that we have to go over. And then I think it's safe to start getting into fetal situs and circulation. So we'll have a few exercises trying to really um, get a great idea of how to determine fetal situs in a clinical setting. And then we'll go on to discuss fetal circulation step by step. I'm really excited that you're taking this journey with me. If you have any questions, feedback, concerns, you can leave it here on YouTube or you can email me at ultraprocertllc@gmail.com. Again, I'm Lachelle. I'm so glad that you're here following with me and joining me and subscribing. I appreciate it all. And I'm just glad and excited that we are learning together because even I, the teacher, is still learning with you as well. So join me for the next lesson next week. Talk to you soon. Have a great day.